and one of the business units of United Health Group here in Brazil. America Medical Services is a hospital network formed by a significant number of hospitals, clinics all over Brazil, and part of the United Health Group, whose mission is to help people to lead healthier lives and to contribute for the healthcare system to work better for everyone. United Health Group has reached 130 countries all over the world. So it's the largest healthcare group in the world with 325,000 providing services to over 140 million people all over the world. And of the 325,000, 125 work in healthcare. Our values are integrity, compassion, relationship, innovation, and performance. All these values are integrated and they make the companies of the United Health Group in Brazil to interact in order to add value to the health market. As part of America's Medical Services, as I mentioned before, we have 18 hospitals, 7 centers of excellence. We have cardiology, neurology, orthopedics, oncology, and also transplant, nephrology, and more recently, we have the maternal pediatric department. We have 37 medical centers in many different specialties, and we are present in 5 states in our country and also in a federal district. And then we are more than 1,700 healthcare workers here in Brazil, and we have conducted hundreds of thousands of medical encounters, surgeries, procedures, providing services, and also in diagnosis. This is the purpose of America's medical services. Our value proposition is based on a mathematical sense of an equation that in the numerator has full quality expressed by the best clinical outcomes possible according to medical proficiency that is provided by our professionals and the experience we provide to people, patients, families, physicians, and everybody comprising our healthcare system. And this numerator is put over a denominator, expenses, efficiency, cost. We want to generate more quality with more economy and efficiency. And this is our purpose. It is to demonstrate that purpose that I have the honor to moderate this panel. And for us to start talking a little bit about value generation, I would like to ask Dr. Conrado Cavalcanti to talk to us a little bit about the concepts of the different lines of care and how they add value to all customers of America's medical services. Conrado, the floor is yours. Thank you, Paulo. So now let's talk about lines of care. So whenever we talk about lines of care, we are talking about the integral care to health, thinking of patients. In order to do that, we need to have a full care system encompassing all phases of the line of care. It all starts with a medical visit, an office visit in the outpatient, and then that trickles down into a cascade of actions. If the patient needs to have tests done, hospitalization, surgery, or any other procedure, is the idea for them to do it within the system and to have a full journey inside Americas. This is a market trend. Other groups are doing that. And what's the differential in relation to other groups? We are adding value-based medicine in all phases of the line of care. So starting in the outpatient, how do we do that? By well-defined protocols for the main lines of care. Each line of care has a chief, an SOE, as we call, for the different lines. And here, today, we have Dr. Osvaldo, a leader in the area of orthopedics, and he is responsible for orthopedics at Brazil level. So how do we monitor the lines of care to add value to patients into the system? Two indicators. The first is related to quality and to patient experience. And of these indicators, I'll give you complications, falls, catheter, streamline infections, surgical outcomes, mortality rates, in the case of oncology, per each type of tumor and staging. In neurology, for example, we monitor time, the door to thrombectomy or door to CT times in the case of stroke. And we also measure performance and how much our teams comply with the protocols. So the second group of indicators have a direct impact in cost, thereby providing benefit to the system and to payers that support all of this. And some examples of those indicators, we have length of stay, either in a regular unit or in the ICU. So how long our patients stay in the ICU, the better those indicators, the lower the cost. Compliance with materials by surgeons, and the more they adhere to the protocol, the lower will be the cost. Several types of indicators like those give us an indication about the system. So whenever things are good for patients, also for payers, it's good for the healthcare system and for the sustainability of our industry. You may ask us, is this all mature, fully implemented? And the answer is no. So it is mature in some of our hospitals, as an example. In cardiology, it's quite mature with cost and performance and quality indicators. They're all very strong in cardio. In Hospital Alvorada in Moema, for example, this line of care is very well implemented with all types of indicators for orthopedics. And transplant is also very well implemented in Hospital Samaritano, Higienópolis. So how do we roll out what we have best in terms of cost, quality, and efficiency for the 18 hospitals, always with a systemic look? This is something we do with our leaders, with Dr. Osvaldo, and I think I'm going to let him talk about orthopedics and innovations that he has brought in to Brazil, not just to our group, but to Brazil. And this will have an impact in the concept of value that we started talking about here. Good afternoon, Conrado, Paulo, everyone. We are going to start talking about line of care in terms of where we come from, and then we are going to try and mention the innovations that we are mentioning and how this can help us within our line of care. We always need to think that the most important for us is to provide the best care for patients. Patients need to be at the center. I am a doctor, Conrado is a doctor, I am an orthopedist. So we always to put patients at the center of care. So about 10 years ago, we started understanding what all these indicators meant in terms of showing what we did and demonstrating whether the care we provided was good or not, and also to provide a benchmark to compare ourselves against other companies. So first we had a contract with Hospital Special Services in New York. They were with us for 5 years for us to define an outcomes benchmark for the patients in the different lines of care, osteoarthrosis, hip and knee, and also lumbar pain, which accounts for the highest number of patients that we have. And why did we choose these three pathologies, because this is part of structure that we call ISHAM, which is a group that developed care protocols for all these patients. So we have brought this to Brazil 10 years ago, also to Hospital Alvorada. And together with HSS, we also started benchmarking our result, our outcomes first in surgery. So we compared what we had here and how we could improve in terms of what they used to do there for hospitals that are number one in the world in terms of orthopedic surgeries. After the 5 years working together, our results became very similar to what they had. And then the contract ended. And then we brought this benchmark to NHAP, and today we do our arthrosis benchmark with NHAP, the Brazilian Association of Private Hospitals. So in terms of, this shows maturities for the system. This provided us maturity in the hospitals, and now we are taking this to other hospitals too, because you already have a know-how how to collect all these clinical and financial indicators. And there are also customer satisfaction, patient and doctor satisfaction rates. So we have embedded all these indicators in our hospitals to understand our positioning as compared to the market. I'm going to give you some examples. So we started first with surgery. So we didn't have maturity to apply it to the entire line of care as we are doing now. So we started with surgery first, with high cost for the carrier, patients that needed or required very good care. And we started provide orientation to physicians in terms of diagnosis, treatment, when each type of surgery was recommended. And then we started implementing protocols of appropriate implants for each, and materials in general for each type of surgery. And then we wanted to have a reduction of cost in terms of the prevalence, having fewer surgical procedures, because we could control that with medical treatment. Sometimes is the best treatment for the patient. Surgery is not always the best treatment. So we had a control of the prevalence of surgeries, providing better care for patients in that gray zone when you don't know whether you operate or not, providing better care with surgery or medical treatment, and also having a more accurate indication of materials and implants. In terms of hip, which is my specialty, I'm a hip surgeon. I do hip arthroscopy, hip replacement surgeries. And then we started first with the data, and then we already were confident in terms of carrier of what we used to do with those patients for 3 months. And this is where we are going to get in this 360 care, the integrated care for all these patients. So we brought to the carriers, and during 3 months, I know exactly what happens to my patient. Then we extended it to 6 months, and in 6 months, I know if I operate with these physicians in this unit, following these protocols, I have the data of the results of satisfaction of patients with medical indicators. You said readmission, reoperation, ICU utilization rate, average length of stay. But more than that, I can also have functional score, the functional status, because they are in our outpatient clinics, are coming to our rehab clinics, and I can give them the functional score, and then we can assess the medical or surgical treatment of the patient. We also measure quality of life, and we brought all of this into our hospital whenever we want to demonstrate how and why we do what we do. And this is how we evolved, and now we are mature enough to look after those patients as a whole. So we are going to get these patients in the beginning at the basis. So you have a diagnosis of osteoarthrosis. They are included in a line of care with a dedicated team that has experience and knowledge to look after that in a dedicated and specific unit. We are implementing it in Americas in Rio de Janeiro. We are doing it in Natal. And here in São Paulo, in Anália Franco, we are going to start on the 15th with these 3 lines of care, because we understood that we are mature enough to get patients from the diagnosis, define the type of the ideal care that they should receive. It doesn't mean that we are recommending surgeries that shouldn't be made or failing to recommend surgeries that should be made, but we trying to understand what is the best treatment for that patient with that disease? And then we get to rehabilitation, and once they come back to the facility.
Well, how do we put robotic in it? A first robot, a Mako robot of a specific company, was brought to Brazil together with Madre Teresa Hospital in Belo Horizonte. And we brought it because we wanted to provide better care to our patients. A robot provides a assertiveness of hip and knee surgery, which is much higher, reducing complication rates such as dislocation, wear of implant. It reduces also length of stay. We reviewed the literature before bringing the robot, and it reduces length of stay, use of ICU. The patient is referred to rehab faster. So we really believe that the robot improved care to patients. Only to patients? No, also to physicians. We also want to uh, consider physicians as users of our hospital. And robotic surgery brings greater precision and better reproducibility of the procedures, better than doing it with freehand. It reduces the learning curve, and that's what helps the surgeon gains more experience. The more surgeries are performed, the more specialized the surgeon is. Theoretically, the better the results. The robot means that more or less experienced surgeons are as assertive in terms of placement of implants. And with that, there is lower risk of complication at early or late stages. The robot also brings a benefit to the HMO because it reduces length of stay, use of ICU, blood. Patients will need fewer physical therapy sessions. 10 cases in the hip, and we've seen faster rehab. After 3 weeks, all patients that I operated could start walking with a cane. It used to take 6 weeks. Now there are fewer sessions of physical therapy that generated 30 to 40, so half rehab sessions. Average length of stay is still very low. There are few cases, and we have a length of stay which is quite good in the hospital. It is the best in Brazil. We used to have 2.1 day, and now it's on average 1.7 days of the use of ICU, about 10%. But I am sure this is going to bring it down because in our cases, we have about 100% of the patients in the ICU. In addition, the robot has also another advantage, which is patients are highly informed. They just Google and learn what have to do. And there is the possibility of using a robot in the surgical procedure. And the robot is going to bring a benefit to the procedure. For example, the patient may get anxious and not sure, and the robot really ensures greater safety. And whenever we ask that to patients, patients feel so much safer. They feel more comfortable to undergo a procedure like that. And HMOs, of course, are going to try to get that, and they can work with us. So this is just an overview, Conrado, to talk more about that. Maybe there are questions that we can address. I believe I have already said a lot, so let's hear from the audience now. Thank you, Osvaldo. Thank you, Conrado. I've made some notes so that we can open our discussion and start really answer all questions from the audience. Let me take the opportunity to thank the production and the group responsible for Initiative FIS and for putting together FIS Week and for giving us the opportunity to hold this panel by America's Serviços Médicos. But let me go back to my notes here. I've seen a correlation between what I call delivering value and line of care, and Conrado has just showed us that, and the incorporation of technology such as the robotic arm Mako, which our system of excellence in Americas is bringing to orthopedics and to patients. So I would like to address some issues that I took note of. You've talked about the quality indicators of orthopedics, which are measured by the International Consortium of Hospital Outcomes. It's the ICHOM. Please tell us more, Osvaldo. What's your take on it? How can organizations really measure outcomes? Outcomes are absolutely essential in our value formulation. When we just focused on quality, why is that? Patients want to be treated and be in excellent conditions after a procedure. And I've heard you say about the reduction of the need of physical therapy sessions, no need to use a walker associated with that. So what can you tell us about the clinical outcomes assessed so far?
Dr. Osvaldo. Well, so while we get Dr. Osvaldo back, and I see that he's moving, I would then like to give it over to Conrado. I also wrote something here of something that Osvaldo called integrated care and the line of care. In here, about the incorporation of this new technology, how do you see that it adds value to this line of care? I think that the incorporation of robotic surgery is, like we said, it needs to be good for patients first. Number one, it needs to be good to the doctors too. And it showed it's good to be for providers, for the owners of the device so that it's feasible. And it also needs to be good for the operator at the end of the day in terms of claim whenever we involve a disease such as arthrosis and hip degenerative disease. So it needs to be good for everyone. And incorporation of robotic surgery is good for everybody, and it will be able to deliver something that is difficult, which is to add value for the four components of the health chain. So it really makes sense. Could you hear Paulo's question? And I can add a provocation. Yes, of course you may. Let's see if Osvaldo is connected. I think he's having some connection difficulties. So let's continue while he's not in here. Oh, great. I can see that Dr. Osvaldo is back gradually. And we can see him. Yes, we can hear you, Osvaldo. I saw the question. Could you hear my initial question about the outcomes that you mentioned when you first started speaking? I think that clinical and financial outcomes for these patients, this is the foundation of our work. We work and we go after it precisely to have the best care possible for patients. And in terms of outcomes, and this is the foundation, this is the first thing that we tried to achieve. Today, there are very few organizations that are prepared to identify the outcomes, very few physicians who really understand how important it is to measure outcomes in an integrated way without any concern of the not minding showing their outcomes, because then we can have improvements in patient care. So this is fundamental in everything. So we don't measure outcomes to punish anyone or to control medical activity, but rather in to provide continuing improvement to our patients. This is our main objective. Great. Well, everything that you said is very timely. I think that Conrado would like to ask another question to you, and I would just like to make sure that Dr. Osvaldo's connection is good, consistent, so that we can have our debate. Can you hear us, Osvaldo? Yes, I can. Oh, good. Osvaldo? Once I asked you about 6 months ago, if you had a problem in your hip, who was going to operate you? Well, the natural patient, I would operate myself, but you can't do that, even though you are one of the best surgeons in Brazil. You gave me the name of a surgeon back then with wide experience, with more than 1,000 cases of hip replacement. Now that you saw the robot working, I'm going to ask you the same question again. Who could operate your hip? Who could give you a hip replacement surgery? Is it the same surgeon you said a few months ago? Or, or would you go for someone who already has some experience in robotic surgery? I think that we need to think a few things about the robot. Robot doesn't teach us to operate. We can only use the robot and make the most of it if we already know how to operate, if we are surgeons already. And now we cannot hear Dr. Osvaldo Pires. I think he's down. And I think we are coming across some connection problems with Dr. Osvaldo. Osvaldo, I'm going to ask you if you may, to assure good connection for us to continue. You are going to talk about the important points of surgical proficiency. So let's wait for Dr. Osvaldo to connect back in a more consistent way. In the meantime, Conrado, I'm going back to you. So we also talked about proficiency. And by the way, you asked a question like that, the medical proficiency. So usually, as Osvaldo said, it's related to the volume, so the 10,000 hours of practice for any activity or any profession. 10,000 hours are important. So my question to you is, do you believe that in this incorporation of technologies, if they will accelerate, and I think you were on those lines, will it accelerate this proficiency, or is it just an extra layer to facilitate and provide convenience and comfort to doctors? I think that it really expedites and shortens the learning curve. He was going to make it clear that the experience and education of the surgeon is very important, but now you have a shorter learning curve. So today surgeons have very different results. So it's a way different having 2,000 surgeries or 20. So once the robot comes in, this delta is going to be way smaller. For you to attain excellent results, it will require many fewer surgeries of experience than what happens today. And I think this reminds us very much of what happened for prostate robotic surgery. So we know that there were some prostate surgeons had excellent results operating through the traditional approach. And once the robot arrived here and Brazilians started operating with a robot, we saw that the results end up being better. And I am sure the same will happen with orthopedic robotic surgery. And now, Paulo, can I ask you a question? Yes, of course, please do. You have a lot of commercial experience in the market for many, many years. You know all the players. And my question to you is, I think that for us offering this product, the value is very clear in the equation that you demonstrated for all stakeholders, carriers included. How do you think this relationship is going to be of carriers with the system at the time of incorporating this technology? Do you see any difficulty for them to see the value, or are they going to embrace it? Thank you for the question and also for provoking another discussion in our panel. I think, Conrado, that when we talk about uh, the formula of value generation within this area, we are talking about a concept, and value cannot be value for one and it's not value for the other. A perfect system value should provide benefit for all involved. That's why I think that the mission of America's medical services, especially, which is to transform the healthcare system into a better system that is good for everyone and helps people to lead healthier lives. And why do I say that? To answer your question, when we say that value is a matter where the order of the factors does change the result. So quality at the top and efficiency cost below. When we talk about full quality, we are talking about quality for the member, for the doctor, the professional responsible for the practice. We are talking about quality for families and quality for those who are funding the system. So quality for someone who's funding the system means the best delivery for those who have trusted your product. So if it's a health carrier, companies, people, large or small companies, people, members, individuals, they resort to a certain brand of a certain product, and they know, they're aware that that carrier did their best to seek who could deliver them quality at the lowest cost possible. And then that's how we believe that the incorporation of technologies that are appropriate for this formula are feasible. Now, note, a long time, uh, payers of the system, of this market, they end up trying to find ways, anyway, of attaining cost savings. And this is because they do not sometimes acknowledge or see the value that is generated. That's why I wanted to talk about measurement. I think that nothing is more important for any system to have some balance, that to have indicators. Indicators are very important. And I think that for a patient, one important indicator is their satisfaction, not feeling any pain, resuming occupational activities, resuming their daily activities. And I can see Dr. Osvaldo talking about recovery of patients at an older age. Imagine going back home already being independent in terms of movements, activities, and how much this benefits the family environment. If anyone should and wants to fund this, assessing this concept is very important because it translates itself into customer satisfaction. And customers, they are all our customers, of the health plan of hospitals and also doctors. So we also need to have the corporate responsibility of making it be cost effective. And therefore, we should think of sustainability in terms of the incorporation of new technologies is paramount. When we look at the arguments or the justifications, whenever we incorporate a new technology here, all the grounds are always very relevant. No carrier just refuses to incorporate something just because it's expensive. In my experience, shows me that the vast majority of health plans, yes, they are worried about cost effectiveness. So we just reverse the formula, the way we say, so the benefit for the cost. So I think that we have sufficient indicators from what I saw here by our Dr. Osvaldo, with indicators as a significant way of incorporating. I don't know if I have answered your question. Yes, you have. And Osvaldo is not here. The ideal would be for him to talk about some specific orthopedic indicators, but I'm going to give you some information of Hospital Alvorada, which is where I work and where we are rolling out this program into other hospitals. First, functional score. So patients who operate, they are worse in terms of benchmarks that we have in Brazil. So we are better to recommend surgery, the first thing that gets into the value formula. And we control many other outcomes, how long the patient stay in the hospital. So length of stay in the ICU, percentage of readmissions, percentage of resurgeries, and functionality. So we start with a functional status that is worse because our patients are worse. We make better indicators, but after 1 year, it gets better. So these numbers are transparent, and what NHAP does in terms of publishing the data, and we can compare ourselves to other benchmarks is very important. This is likely to grow, and once this becomes public and carriers have more access to this information, I think that system like ours will provide more value to the system, will gain strength. Do you agree with me?
Couldn't agree more. Couldn't agree more. In fact, systems such as ours, they are already taking a position which is fundamented on value generation and indicators. I really liked your initial remarks, which shows that we are on the right path. It's always difficult to say that we have a solution, and we know it's a journey. So I am very glad to see that we have incorporated in America Serviços Médicos a new technology that speeds up, that ensures good outcomes and satisfactions of physicians, and also has a possibility of providing sustainability and funding this model. We're getting to the end of our panel, and I guess Osvaldo is back and dealt with a problem of connection and can now talk to us. Conrado, can you go into your closing remarks? We were talking about indicators, sustainability, pertinence. Let's go into our closing remarks, please. I'm sorry, there was a problem of power shortage here at home. It's important to offer a 360-degree experience to our patients and how we can make sure that robotic can help us. I think we have provided that, and that has added quality information to those who were with us. Thank you very much, Osvaldo. Let me thank you once again for just bringing us some knowledge about robotic arm and care. Thank you, Conrado, for the discussion and for the interaction, because as a moderator, I could really contribute thanks to your also interactions. Thank you very much for the group. Thank you, Initiative FIS for bringing us on board. And I wish you all a great, productive week, thanks to the content that was generated here. Thank you very much. Have you all a great afternoon. And back to the production. Thank you.